I want to talk to you today about holding solutions. These are the solutions that we place our grafts in. There's solutions where grafts will often stay for several hours at a time, and therefore they're quite important to the overall hair transplant process. Now, in hair transplantation, there are a number of different holding solutions. There are holding solutions that are quite expensive, and there are holding solutions that are quite inexpensive. You will find that the majority of physicians who perform hair transplant surgery use the least expensive holding solutions. These include normal saline and Ringer's lactate that are tried and true in the minds of most hair transplant physicians. However, the question is, can we improve the survival of our grafts and the viability of our grafts by improving the quality of the holding solutions that we use on our patients? There are 4 phases in a hair transplant that can affect the survival of grafts. These include the harvesting of the graft and the production of grafts. This is done either through follicular unit extraction, which I believe is the preferred method, or through strip surgery. With strip surgery, the surgical technicians are responsible for dissecting the grafts, and of course the procedure depends somewhat on their skill and the monitoring physician. Once the grafts are cut, or once the grafts are extracted from the donor area via follicular unit extraction, they are placed in a holding solution. And this will be the primary topic we will discuss today. The next phase is placing the grafts atraumatically so that they have the highest probability of survival. And finally, the placement of the grafts. This can result in revascularization injury or reperfusion injury due to the production of free radicals. So the question is, how can we improve the viability of our grafts? Is there a way that we can do things better? And is there an optimal holding solution and an optimal temperature for hair transplant grafts? One of the first studies that I ever did was to see how fast I could cut a graft, extract a graft, and implant a graft all via follicular unit extraction. I wanted to see if rapid transfer of the graft from the donor area to the recipient area would improve the survival and also determine whether it would allow the graft to continue growing following transplantation. We all know that when we extract grafts from the donor area and transfer them to the recipient area, they go through an effluvium phase. Many people call this telogen effluvium, but honestly it is an anagen effluvium because the hair falls out immediately from the growing phase, not following a resting phase. So in an anagen effluvium, the hair will typically fall out in 2 to 4 weeks following surgery, and generally between 2 to 3 weeks following surgery. And what I found was that rapid implantation of the grafts did not prevent anagen effluvium. We still don't know whether rapid implantation will improve survival, but there is cause to believe that it does not. So the question is, are there things that we can place on our grafts and our holding solutions that will help improve the overall survival of our grafts? These would be sort of like a boost to the graft to help them grow and survive the reimplantation process so that we have a faster yield and a better yield. So the question remains, what is the ideal holding solution? Again, there are inexpensive solutions which most physicians use. These include normal saline and Ringer's lactate. There are expensive solutions such as hypothermosol, Wisconsin solution, and platelet-rich plasma. And the question is, what is the ideal temperature? Some grafted tissues such as liver and cardiac muscle have a better survival rate at specific temperatures. And then what about anti-apoptotic compounds such as BMOV, which is one of the vanadium-based compounds which has antioxidant capacity? What about the addition of antioxidants such as glutathione and vitamin E? And how about growth stimulating factors such as activated platelet-rich plasma? And finally, what about the addition of adenosine triphosphate or ATP, oxygen? These are all questions that remain to be answered, but there definitely appear to be far better combinations and solutions that are far superior to normal saline and Ringer's lactate. Like it or not, cost seems to play a role in what physicians use to store their grafts in. The least expensive agent is normal saline. And you can see that for a case of 12 1,000 cc bottles, you'll pay approximately $44.20. And physicians are notoriously known for minimizing the cost of their procedure. And the question is this to the detriment of the patient? Are there better solutions that cost more money? What about BSS, which is a buffered solution? Unlike normal saline, a buffered solution will not have a declining pH as time goes on during the storage process. It is more expensive. Ringer's lactate. It's more expensive than normal saline, but what advantages does it offer? It is probably better than normal saline, but it does contain calcium, which is a known initiator of apoptosis. Then there's hypothermosol. This is a solution which should be used in cold storage, and cold storage is known to reduce the metabolism of the cells and therefore might well improve the viability of the cells. In general tissue transplantation, most organs are chilled, and they are chilled in a cold storage medium. And since most physicians chill their grafts, the question is, should they be chilling their grafts in normal saline? Then what about the addition of ATP, Vitasol? A liter costs $1,325, but it supplies necessary nutrition to the grafts when they are out of the body and can no longer produce ATP in an aerobic means. They must produce energy through glycolysis and anaerobic metabolism, and this can result in the production of free radicals upon reimplantation of the grafts. So Vitasol appears to be a valuable addition to the storage mediums that we use. So let's look at the literature as it relates to hair transplant surgery and storage solutions and temperature. Dr. Kim found that storage in cold mediums did not improve survival of the grafts for the first 5 hours. Of course, he was evaluating normal saline. Dr. Biener found that cold storage improves the survival rate of grafts exposed to crush injury. And what he did was he crushed grafts with forceps and then he placed part of the grafts in a cold medium of normal saline, and then the other grafts he placed in an ambient temperature medium, and then he reimplanted them. And he found that the growth rate, the survival rate of grafts that were in the cold medium had a higher yield than the grafts that were stored in an ambient temperature. And what this indicated was that grafts that are traumatized during placement or during graft preparation might have a higher survival rate if they are stored in a cold medium. Dr. Ubel noted that when he stored his grafts in platelet-rich plasma, he had a 15% increase in survival rate. The study has not been confirmed. Dr. Lee found that PRP-treated side of his recipient area grew faster than the non-treated side. Dr. Cooley did an out-of-body study where he found that free radical scavengers could help protect against reperfusion injury. However, he did not do a side-by-side comparison on a patient or a series of patients to determine if free radical scavengers improved the yield. Dr. Biener did a study where he evaluated a prolonged period of graft storage prior to reimplantation. And what he found was that hypothermosol and ATP combined had a higher survival rate than normal saline when grafts were stored out of body for a prolonged period of time. Dr. Perez Mesa noted no difference in ambient temperature versus 4 degrees Celsius. Dr. Kim did a follow-up study in which he showed in normal saline that there was no improved survival rate in 4 degrees Celsius versus ambient temperature for the first 6 hours. Then there was a decreased survival rate for both the ambient temperature and the graft stored at 4 degrees Celsius. However, there was a better survival rate for the graft stored in a cool environment. This suggests that, once again, a cold environment helps protect against the trauma of prolonged storage. And then Dr. Go has done many studies using antioxidants, anti-apoptotic factors, and growth factors. And what he feels is that the addition of BMOV, antioxidants, and growth factors may improve the survival rate of FUE grafts and partial follicular unit extracted grafts. He does believe that normal saline will reduce the survival rate of follicular unit extracted grafts and also grafts that are harvested via the drip method. Other studies that have been done, Dr. Kian noted that 0 degrees Celsius storage was superior to 4 degrees Celsius storage for long-term preservation. Dr. Raposio found no difference in hair shaft elongation for grafts stored at room temperature versus 1 degree Celsius. However, there is no evidence that hair shaft elongation studies suggest a better survival rate or play any role in the survival rate of grafts. Dr. Krugler created the Moser solution, and he found that it prevented antigen effluvium in a series of patients. However, this solution is not available on the open market, and the veracity of these claims has not been confirmed. He also found that PBS containing B12 increases hair shaft elongation. Again, hair shaft elongation is not necessarily linked with a better yield or survival rate of grafts. And Dr. Parsley did a side-by-side comparison study where he found that the coverage produced by grafts stored in hypothermosol was better than grafts stored in plasma-lyte A. And the results of this study are depicted to the right. The bottom line is that we need more comparative studies to evaluate the benefits of the various storage solutions, including the optimal temperature. All cells need energy to survive and metabolize and grow and carry out cellular functions. When we eat, we produce glucose, and the glucose is converted into adenosine triphosphate, or ATP. There are methods in which we produce ATP, two primary methods, and one is glycolysis. This produces 2 ATP for every glucose, and this is produced in an anaerobic environment. Then we have the Krebs cycle, in which we produce ATP, and we produce 37 ATP for every glucose. So in aerobic conditions, glycolysis produces pyruvate, which is further oxidized via the Krebs cycle to produce ATP. But in anaerobic conditions, pyruvate is converted to lactic acid, and the glycolysis, the end production is hypoxanthine, and hypoxanthine in reperfusion produces free radicals, and these free radicals can oxidize molecules on contact. So it's important that we have ATP, but unfortunately, following transplantation, or extraction of grafts from the donor area rather, the grafts no longer have oxygen. So all the ATP must be produced by glycolysis. And glycolysis is an inefficient means of producing ATP, and it has serious consequences following reimplantation. In biopreservation, we can store tissue at room temperature or ambient temperature, or we can reduce the temperature further. The question is, does reducing the temperature improve the survival rate of grafts? And many studies using organ transplantation suggest that lower temperatures improve the survival rate of grafts. The hypothermic continuum suggests that we should reduce the temperature of the biopreservative. At room temperature, we are at 20 to 25 degrees Celsius. This is well below the body temperature of 37 degrees Celsius. However, should we reduce the temperature to between 0 and 10 degrees Celsius? Now, in most studies, we will find the term 4 degrees, or the mark 4 degrees Celsius, as the temperature studied. And in reality, 4 degrees Celsius has no rationale other than this is when water has its highest density. Nevertheless, you will oftentimes see studies related to hair restoration surgery where the target temperature is 4 degrees Celsius. However, dropping the temperature has negative consequences to cells. Progressive drops in temperature result in rapid gains of calcium, loss of intracellular potassium, a gain in sodium, intracellular acidosis, leaky membranes, and possible apoptosis. So chilling alone is not necessarily the only solution. We have to consider what is the optimal storage medium in which to chill our grafts. Now there's something called the Q10, and the Q10 refers to oxygen consumption. For every decline in 10 degrees Celsius, the oxygen consumption will decrease by 50%. So that we can see at 5 degrees Celsius, the oxygen consumption is 6% of that at 37 degrees Celsius. But cooling provides short-term in vitro survival through a decrease in metabolism and a reduction in oxygen and nutrient demand. So cooling does provide benefits to the cells. However, hypothermia without manipulative intervention can lead to progressive cell injury during each of the 3 phases: cooling, maintenance of cooling, and rewarming. So in other words, manipulative intervention would be the storage medium that we store our tissue in. And as we've shown, cooling by itself can cause negative consequences to cells, but by storing the cells in the optimal temperature and the optimal environment, more importantly the optimal environment in this case, we can minimize the negative consequences of hypothermia, and we can help protect the cells through the 3 phases of cooling, maintenance of cold, and rewarming. One of the problems with storing tissue on ice is that we really can't control a specific temperature. The ice may chill the temperature of the grafts well below 4 degrees Celsius, or if the tissue in the petri dish loses contact with the ice, the temperature in the petri dish can rapidly rise, and grafts like nothing more than to maintain a constant temperature. When you allow the temperature to rise abruptly, let's say toward ambient temperature of 19 or 20 degrees Celsius, this can have a damaging effect on cells. And then, when you lower the temperature again by adding more ice to chill the temperature of your grafts and your holding station, the grafts undergo another stress by reducing temperature abruptly. So, in order to overcome this, I created a graft chiller plate. And with the graft chiller plate, I can set a specific temperature. If I want to evaluate my grafts at 4 degrees Celsius, I can set the temperature at 4 degrees Celsius and evaluate the growth of the grafts at that temperature. Currently, I'm looking at 8 degrees Celsius as a more optimal temperature to store grafts, and I set my chiller plate at 8 degrees Celsius. And as long as those grafts are on the chiller plate, they will maintain that constant temperature. And I no longer need to worry about grafts abruptly becoming too warm and then having to chill them again. Now, one of the things that tissue may not like is to abruptly go from body temperature, and in the donor area of the scalp, the temperature is probably closer to 33 degrees Celsius. And then we drop it from 33 degrees Celsius to ambient temperature by taking the grafts out and then chill it. So what I like to do, rather than abruptly moving from 33 degrees Celsius to 8 degrees Celsius, is I take the tissue out and I put it at ambient temperature, or room temperature, for a period of approximately 5 minutes. And then after 5 minutes, I drop the temperature further to 8 degrees Celsius. And then prior to implantation, I take the grafts from 8 degrees Celsius and I place them at room temperature so that they can reacclimate, and then place the grafts back into the recipient area, which is probably close to 33 degrees Celsius. So rather than move my grafts abruptly from 8 degrees Celsius to 33 degrees Celsius, I gradually warm the grafts. And I feel that this has the capacity to reduce